Good afternoon. My name is Carlen Yuen. I am a neuro-oncologist and an assistant professor of the Department of Neurology at the University of California, Irvine. Today I'm going to be presenting a case of a high-grade glioma not elsewhere classified in an older adult with discordant genetic and epigenetic analyses. I have no disclosures. We are going to discuss the background, the case, discussion, and finally wrap up with the conclusion. The World Health Organization's classification of central nervous system tumors has undergone multiple revisions to improve the diagnostic accuracy of high-grade gliomas. The prior classification schemes relied solely on histologic features. The more recent classification schemes have been updated to integrate molecular features with the existing histologic criteria. Each iteration of the WHO classification refines and expands the diagnostic categories, reflecting the exponential increase in our understanding of genetic and epigenetic mechanisms driving CNS tumors. More recently, DNA methylation profiling has emerged as a formidable diagnostic tool for CNS tumor classification. Methylation involves the addition of a methyl group to a cytosine nucleotide, predominantly occurring within CpG sites wherein a cytosine nucleotide precedes a guanine nucleotide. Methylation profiles are DNA methylation patterns defined across the genome. These are fingerprints that identify the cell of origin. These DNA methylation patterns are grouped into classifiers that are utilized for the distinction and classification of tumors. Methylation profiling is increasingly being used as an ancillary diagnostic tool to reliably diagnose otherwise equivocal high-grade glioma tumor cases and to identify new CNS tumor entities such as high-grade astrocytoma with pyloid features, otherwise known as HGAP. HGAP is a described high-grade astrocytoma that is exclusively diagnosed by its distinct global DNA methylation signature. Most commonly occurring in the posterior fossa, the morphology of HGAPs is diverse, with some overlapping features between glioblastoma and pilocytic astrocytoma. However, characteristic histologic features of pilocytic astrocytomas, such as Rosenthal fibers, are often lacking despite the pyloid designation. HGAPs typically behave more aggressively than benign pilocytic astrocytomas, but reportedly have a better prognosis compared to IDH wild-type glioblastomas. HGAPs frequently harbor alterations in the MAP kinase pathway, such as NF1 mutations, FGFR1 mutations or fusions, and BRAF mutations or fusions, accompanied by CDKN2A and ATRX gene alterations. HGAPs do not harbor EGFR amplification, 710, gain or loss respectively, and rarely harbor TERT promoter mutations, which define molecular alterations for glioblastoma. Along with these biological differences, which remain under investigation, divergence in treatment options between pilocytic astrocytoma and glioblastoma also remains. Intervention for this new CNS tumor entity, which lies amidst a benign and a malignant tumor, is challenging. Evidence for HGAP is scant, with few reported cases and a tenuous association between treatment and patient outcomes. We present a case of a 72-year-old male with a challenging high-grade glioma not elsewhere classified, showing characteristics of both HCAP and glioblastoma that did not fit neatly with any of the existing tumor entities in the 2021 WHO classification of CNS tumors, despite molecular profiling and DNA methylation analysis. We report on his response to standard of care glioblastoma treatment for his high-grade glioma not elsewhere classified. A 72-year-old male presented to our institution with a 2-day history of altered mental status and emesis secondary to a 4.3 centimeter enhancing mass in the left temporal region detected on brain MRI with and without contrast, as you can see here. His neurologic exam was notable for memory impairment, followed by a subtotal resection, which left a residual 1 centimeter nodule in the medial aspect of the resection cavity, as you can see here. On histopathology, you can see these sections reveal glial cells with spindled and hyperchromatic nuclei with compact growth pattern and intervening areas of microcystic background. And note the pleomorphic bizarre cells with smudgy chromatin in this panel here. In other areas, tumor cells with round nuclei and scant chromatin show infiltrative growth patterns and high-grade features. Note the entrapped cortical neuron here with the green arrow and mitotic figures here with the black arrows and incipient microvascular proliferation. Some high-grade areas show pseudo-papillary architecture due to geographic necrosis here with the red arrows and viable tumor cells clinging around the vessels. Here you can see tumor cells are positive with GFAP, weakly positive with somatophysin. Neurofilament stain highlights entrapped axons in high-grade areas. P16 is essentially negative, which can be interpreted as a loss in the tumor cells. ATRX is lost in the tumor cells in the high-grade areas and retained in the endothelial cells. The Ki67 index is approximately 40% in high-grade areas. We perform targeted DNA-based next-generation sequencing, evaluating all exons of 479 cancer genes and select introns and upstream regulatory regions of 47 genes, including genes that are critical for glioma diagnosis, including IDH, EGFR, MET, FGFR, NF1, BRAF, PIK3CA, PTEN, CDKN2A, CDK, TP53, RB1, MDM2 and 4, H3F3A, CIC, and FUBP1, also ATRX and TERT. NGS results from our case demonstrated an activating hotspot in the FGFR1 oncogene and a PN546K variant allele frequency of 82% and homozygous deletion of CDKN2A and B tumor suppressor genes on chromosome 9 in a background of additional copy number changes. There were also alterations found in DNMT3A and TET2 noted. the Infinium methylation EPIC kit. Our patient's tumor was compared to an existing database of known CNS tumors using machine learning algorithms, including random forest and uniform manifold approximation and projection for dimension reduction. The class prediction was reported with a calibrated confidence score ranging from 0 to 1 with a score of greater than 0.9, considered a match. This case was analyzed using versions of 11b6 and 12b6 of the DKFZ classifier and the NCI Bethesda classifier, versions 11b6 and 12b6. This tumor matched to the methylation class anaplastic astrocytoma with pyloid features, which is the name this classifier uses for HGAP, with a confidence score of 0.25, and to the MC pilocytic astrocytoma with a confidence score of 0.35. These matches were considered no match due to the low confidence scores. On the NCI Bethesda classifier, which uses 10 different classification algorithms, this tumor matched to MC-HGAP on 8 of the 10 classifiers with a high confidence score ranging from 0.96 to 0.99, but it matched to MC pilocytic astrocytoma on the remaining 2 classifiers and on the UMAP embedding of the DNA methylation array data. While the histological and molecular features of this astrocytic glioma fulfill all the desirable criteria for HGAP, given the lack of concordance between the classifiers, an integrated diagnosis of high-grade glioma NEC was favored. NEC, not otherwise classified, is an indicator that this tumor does not conform to a specific well-defined diagnostic entity in the WHO 2021, despite adequate genetic and epigenetic testing. The most recent WHO classification of CNS tumors incorporates histologic, genetic, and epigenetic features into an integrated diagnosis, which is expected to increase the accuracy and reproducibility of the diagnosis. Morphologic features in this case include infiltrative growth patterns, frequent mitoses, necrosis, and microvascular proliferation. These were consistent with an aggressive astrocytoma. In the pre-integrative diagnosis era, prior to the 2016 WHO classification, these features may have been sufficient to diagnose this tumor as a glioblastoma. However, the tumor lacked TERT promoter mutation, EGFR amplification, and polysomal 7, monosomal 10, which are characteristic genetic alterations of an IDH wild-type glioblastoma in adult patients. Given the glioblastoma IDH wild type is defined by what is lacking, the lack of IDH1 and 2 hotspot mutations, rather than what it is harboring, many opportunities exist to identify new CNS tumor entities. HGAP is one newly defined tumor type among high-grade gliomas wherein a match to methylation class HGAP on DNA methylation profiling is an essential criterion. Our case demonstrates unusual histologic features, including a relatively lower grade region with a compact growth pattern. A pilocytic astrocytoma with high-grade progression designation was considered given the combination of the MAP kinase pathway alteration with the FGFR hotspot mutation and ATRX loss in the high-grade areas. However, the lower grade regions did not fit neatly into the characteristic pilocytic astrocytoma morphology. The presence of scattered pleomorphic cells as well as pseudopapillary architecture also raised the possibility of a high-grade glioma with pleomorphic and pseudopapillary features, HPAP, a recently proposed tumor entity with frequent TP53 alterations and monosomy 13q, but these were absent in our case. The histologic and molecular features also raise the possibility of HGAP prompting DNA methylation profiling. Clinical data garnered from limited existing literature for HGAP corroborated with our patient's tumor to a limited extent. HGAP predominantly affects males with a mean age of 44 at the time of surgery. Our patient was male, but significantly older at the age of 72 at the time of surgery. Although HGAP has a predilection for the posterior fossa, 26% of cases occur in the supratentorial region, as in our case where the tumor was located in the temporal lobe. An infiltrative glioblastoma-like morphology is observed in 86.7% of HGAP cases, substantiated by the morphology observed in our patient's tumor. Necrosis and or microvascular proliferation are observed in 62.3% of HGAP cases, and these were present in our case. While some foci showed a compact growth pattern, Rosenthal fibers and classic pilocytic astrocytoma morphology were absent, in keeping with the lack of piloid features in the majority of HGAPs. Mitotic activity ranges from 0 to 6 mitoses in HGAP tumors, which was validated by the mitotic count of 6 per high-powered field in our patient's tumor. The Ki-67 proliferative index of HGAPs ranges from 1 to 30%, but the Ki-67 index in our patient's tumor was significantly elevated at 40%. DNA methylation profiling was contributory but insufficient to establish a definitive diagnosis in our case. While some of the classification algorithms used in the NCI Bethesda classifier match to the methylation class HGAP, others, including UMAP embedding, match to the methylation class pilocytic astrocytoma, while the DKFZ classifier resulted in a no match to anaplastic pilocytic astrocytoma. Collectively, the lack of concordance and no match on DNA methylation profiling yielded a final diagnosis of high-grade glioma not otherwise classified. The recent discovery of HGAP highlights the role of DNA methylation profiling in uncovering new CNS tumor entities. Our case may represent a new emerging CNS tumor type or subtype that is yet to be defined, or more likely it is an unusual variant that has yet to be incorporated into the existing databases. Nevertheless, an astrocytic glioma with DNA methylation profile of HGAP as the sole diagnostic criterion of HGAP is not fully integrative of histologic, genetic, and epigenetic features of a tumor. Furthermore, it poses challenges to issue a specific diagnosis in cases such as this one. Accordingly, refraining from forcing a diagnosis is imperative. To our knowledge, there's only one other reported case of a suspected HGAP with a no match on DNA methylation profiling, resulting in the diagnosis of high-grade glioma not otherwise classified, but treatment was not reported and remains a knowledge gap to be explored. Additional cases with similar clinical, histologic, molecular, and epigenetic features are required for confirmation. Treatment for high-grade gliomas that do not conform to existing tumor entities in the WHO classification is challenging. While standard of care treatment exists for glioblastoma, treatment for HGAP has not been established. Treatment with the STOOP regimen, neurosurgical resection, radiation therapy, temozolomide, and targeted therapy have been reported with minimal evidence to support the efficacy and unreported long-term patient outcomes. Targeted therapy, including therapy with FGFR inhibition, is an emergent treatment intervention for tumors with these mutations or fusions. Preliminary evidence shows that single-agent FGFR inhibitors in recurrent gliomas with FGFR1 mutations can achieve durable responses. However, our patient's tumor had an activating FGFR1 P9546K mutation that has been reported to carry therapeutic resistance to these FGFR inhibitors. The lack of uniform treatment options for the genetically distinct H gap and lack of data on treatment for unmatched high-grade gliomas not otherwise classified pose challenges for treatment decision-making in our case. Although our patient's tumor was not classified as either a H-gap or glioblastoma, both have poor prognosis and arguably necessitate aggressive therapy. Our patient was treated with standard of care chemoradiation using the Stoop regimen, and at time of publication, he remains clinically and radiographically stable 15 months from the initial diagnosis. Our case adds to the insights into the diagnostic challenges associated with discordant histological, molecular, and methylation results for individual patients. In conclusion, DNA methylation profiling is a powerful tool for uncovering new CNS tumor types and can be used as an ancillary diagnostic tool to accurately classify challenging cases. Nevertheless, unusual cases that do not fit into established diagnostic classes exist. While some of these cases may potentially represent novel, unidentified CNS tumor types, certainly all of them pose challenges in treatment decision-making for individual patients. Future investigations should be directed at understanding the therapeutic options and the associated patient outcomes for newly defined high-grade glioma entities. Thank you for your attention.